Thank you very much, Win, for the kind introduction, and thank you to the conference organizer for having me to talk in this session in a topic that I'm very passionate about in cognitive impairment. Today, I'm thinking that, I'm guessing that it's going to be quite different than most talk about cognitive impairment in people with HIV. My goal today is to really comprehensively provide kind of the overview picture focusing on the cognitive care cascade from the field, from the perspective of cognitive field, rather than looking through the lens of HIV-specific care. Some of the things that I will not touch a lot today is like the terminology that some would say is still debatable and quite confusing, and sometimes drives people away from the cognitive part, brain health of people with HIV. And the pathophysiology is something that I will not get into much today, but again, more on the kind of the care cascade that we might be able to integrate into our care in HIV clinic. So very briefly, although I'm saying I'm not going to talk too much about it, but I need to mention a little bit in terms of terminology. So kind of these are the timelines, very briefly, of neurology-related HIV. Some of the term like AIDS dementia complex was back in the late 80s, HIV encephalopathy as well, in the 90s, in the early 90s, around the time I was born. So HIV-associated dementia, or HAD, and soon thereafter, people realized that, okay, cognitive impairment doesn't always have to be dementia. There's a milder form as well. And then we fast forward for a decade, and I'm quite certain that a lot of people here in the audience have seen this term before. HAN stands for HIV-associated neurocognitive disorders. It's like a nickname of the classification from Frascati classification. It's like the name in the city of the Italy where they held the meeting. Basically, it categorized neurocognitive disorder in HIV, people with HIV in three categories, three severities: asymptomatic neurocognitive impairment, ANI, mild neurocognitive disorder, MND, and HIV-associated dementia, or HAD. This distinctions is within the next two columns, the impairment in at least two cognitive domains. The numbers are the same, but the degree is different. As you can see, for HAD, it has to be markedly impaired. Quantitatively is equal or more than 2 SD compared to the norm. Another difference is the interference with activities of daily living. Of course, for ANI, there's no interference, mild interference for MND, and marked interference for HAD. Now, in my opinion, in the current date, I think the exclusion of pre-existing causes of cognitive impairment is getting tougher and tougher when we integrate the knowledge from the cognitive field. For example, like for Alzheimer's disease, we now know that the abnormal biomarkers, the abnormal proteins deposited in our body decades or even more before we have the symptoms. So would that count as pre-existing cause or not? I think that's debatable, and still we don't have that answer. And it's very, very tough to detect those things without the symptoms prior. Usually I would end here in terms of terminology, but 2 years ago, there's a new one, HABI, HIV-associated brain injury. And the concept here is to consider HIV as one of the causes of cognitive impairment along with other causes of brain injury, as you can see on the right-hand side in the table on the lower portion. And one of the key things when we talk about HABI is whether or not the patients have viral suppression, because it's going to kind of link to the pathology, the active or involvement of the HIV towards the brain. Now, as I mentioned, I'm not gonna, I'm just laying the ground in terms of there are some terminologies here and there. But when I look back and think when we given our care to the patient sit right in front of us, I really think that sometimes, and learning from the experience of a colleague as well, these terms may get you kind of like restrictive a little bit of thinking ultimately that it has to be something with HIV, which at least from the neurology perspective, that's not the right way to do differential diagnosis. So I think we would like to look at from an overall holistic cognitive field approach, similar to when we giving care of hypertension, diabetes. we use the knowledge from that field, but then we add on, and that's the word I'm going to use quite a lot, we add on some of the unique consideration for HIV. For instance, like when we treat diabetes, we use the medication that we usually use for diabetes care, but we have to consider that, okay, that we have to be cautious about drug-drug interaction between dolutegravir and metformin, for instance. Now, moving on to kind of the burden of the disease, very briefly, I use the number 50, and approximately, depends on the study, approximately 50% of people with HIV is living with cognitive impairment, and there are many risks to that. Now, unfortunately, the most important risk factor is aging. Other risks, perhaps genetics, race, HIV legacy effect, history of AIDS-defining illness, what's your lowest CD4 count, any previous brain opportunistic infections, and many more. Mental health, ART toxicity, social isolation, cardiovascular disease risk, so on and so forth. Now, this is not a comprehensive list in any way. And now, I think to summarize in our mind, perhaps categorize into two categories. And the up top, the color is quite not very clear here in the monitor. The up top here is the unmodifiable risk factors, and down below is modifiable risk factors. So when we're giving care, of course, the modifiable risk factors are some of the things that we can definitely do something about it to help our patients. Now, as I mentioned, aging is unfortunately the most important risk factors. When we look at the epidemiological data of the age of the people with HIV, more and more people with HIV are getting older. So it is not a surprise to anticipate that the proportion of people with cognitive impairment will also increase. One of the unique things, at least from our data in Thailand, is that those who are in the older group of people with HIV, they tend to do better. ART coverage very high, viral suppression very high. The key message I want to point here, again, coming back to the lens or the perspective of giving cognitive care, is that HIV-specific management for this group of people might not be a lot. Of course, the first thing is that we have to check whether virus is detectable or not. The second thing is perhaps looking towards any ART toxicity that can affect brain health. F5 brains, for instance. OTS inhibitor has been reported to associate with small vessel disease in the brain, theoretically can lead to cognitive impairment, for instance. But as you can see, that there might not a lot of things that we can do. So again, hitting back to the same comment that we really have to look at the broader side of things, holistic approach of the cognitive field, rather than pinpoint down to the HIV specific part of it. But there are some similarity is still there. So like the top here is like the cognitive trajectory, which I will get into it in a few minutes in the slide, that we use in general for when we're giving care in cognitive clinic. We have the stage of cognitively unimpaired to mild cognitive impairment, or MCI, and of course, at the end of the spectrum is dementia. Now, when we look at hand, there's similarities there. We start with cognitive unimpaired, ANI, MND, and of course, HAD. Now, when we look about risk factors, it is very important to know that things that happen to people without HIV also occur in people with HIV. So I think that's the thing that should not be neglected. You know, Alzheimer's can happen in people with HIV, vascular dementia can happen, cognitive impairment from sleep issue can happen as well. But we add on the things that may be unique to people with HIV, like the HIV effect, the ART effect, the fact that people with HIV have a higher chance of having higher number of comorbidities compared to people without HIV, for instance. And this is show you that whether I'm talking about MCI, dementia, these things are, I would call it syndrome. So it's not a disease per se, it's a syndrome. Kind of like when we see patients with congestive heart disease, anemia, kidney disease, we should not be satisfied with just that. We should always go deeper than that to find the underlying etiology that caused that syndrome. And again, these things are for general population, for the Alzheimer's associations data, but it can definitely happen in people with HIV as well. So that leads me to the theme that I want to talk about, and three things. The first thing is about the screening. There's no consensus recommendation. I'm trying to look at it in an optimistic way, that so there's like no right and wrong answer. You can tailor to best fit to your setting. The second thing is the detection. We want to have ways to detect symptomatic people. And last but not least, after detection, we need to see the care cascade. And again, I'm emphasizing that I'm trying to look at from the different approach, from the cognitive field as a whole approach, rather than narrow ourselves down just to HIV specific. But definitely add on some of the HIV unique features in that. So on the left-hand side is some of the statements or recommendations from a lot of organizations regarding cognitive screening among people with HIV. So basically it's inconclusive. There are different recommendations out there. Now on the right-hand side is for people without HIV, a little bit more consensus, but basically insufficient evidence to recommend screening asymptomatic people. So that leads me to asymptomatic. I think we really have to be cautious on that. Because some people may not be able to report their symptoms, because unable to report your symptom is basically self-report. Now there might be a couple of reasons to that. One of the things is the symptoms, it's not pain, it's not chest pain or palpitation that you can feel like, but it's very subtle. And when they walk into the clinic and see a lot of busy things going on, they might feel, I don't want to talk about it. Another thing that happens is that they might not unaware that they are experiencing cognitive symptom. Cognitive symptom is not only memory. If it is memory, I think people usually be able to report that, but it's not only just memory. And the next slide, I will show you different domains of cognitive function. And I actually invite everyone to see the translation of cognitive function in their own language. For instance, like in Thai, the translation is the word that I have never known before since I was born. So it's very difficult to communicate these things to the patient. Now, typical solutions in practice when we do in cognitive clinic is allowing more time for detailed history taking might be tough in HIV clinic, especially in our region. But another thing, one of the first things that they taught us to give cognitive care is to always involve other informants, not just the patient themselves, because observation from near a close person is very vital. Now, this is a big obstacle for people with HIV because usually they come alone. I rarely see their loved one that coming in that I can ask them about potentially any cognitive symptoms. And this is the graph, the figure that I want to communicate that there are many things, not just memory, when we talk about cognitive symptoms. So as you can see, it's quite tough to really know that, okay, you have those symptoms beside the memory. So that leads me to how are we going to raise awareness or even talk about it? Again, looking optimistically, there's no recommendation, no consensus guideline yet. So basically what you need, in my opinion, is something that can kickstart the conversation. One of the things that we use in Chulalongkorn University is CSARS, of course, translated in Thai. Cognitive Self-Assessment Rating Scale. So the original one had 12 items, exploring memory, attention, executive function, social function, etc. And each question have, two questions, like how often do you experience that and how much does it interfere with your life? So that ends the first part of my talk, is that there's no recommended screening, but I think the key here is try to get whether the patient has any symptoms. There are some obstacles like the informant I think is very, very tough to tackle, but initiating or kickstarting the conversation, I think there's some possibilities in that. Now, after we notice that, okay, our patient might have some symptoms. Now, the next step is to really do like a neuropsych test to really detect officially. And I use this figure, again, from the cognitive field. I bet it is specifically for Alzheimer's disease. Some of the things might not be relevant to many etiologies. So for Alzheimer's disease, it's one of the diseases that they have biomarkers to diagnose. Now, when we look through this graph, I assume that in HIV clinic, the sequence might not be exactly like this. Patient and family history taking. When we talk about integrative care of geriatric syndrome or cognitive care or even mental health, I think we instantly go to like the questionnaire or the assessment, like PHQ-9, MOCAR, for instance. So I'm going to switch that a little bit. So I think most of our experience in HIV clinic might be in this way. patient history, family history, and then we do some questionnaire or some assessment. And if we think that we have to do something more, we send the blood test, for instance. Before I move on, I have to talk about cognitive trajectory first. This is a cognitive trajectory for those with pathology, not normal aging. Okay, not normal aging. For pathology in general population, the term would be around 3 to 4 terms. I put these 3 lines right here. So of course, starting with cognitively unimpaired, SCD is a relatively new term, but I think it's been around like 5 to 10 years now. Subjective cognitive decline. Some might use the term subjective cognitive complaint, but I think it's a little bit stigmatized. The next step, the next one is MCI, of course, mild cognitive impairment, and last but not least, dementia. This is the conversion rate for each year from the, I believe they have from the US, but again, from the general population. The key thing again, the most important thing always, this term, SCD, MCI, dementia, is a syndrome. It's not a diagnosis, it's not a disease. We always have to find that underlying causes. And if your patient is lucky, those causes will be reversible. From my own experience, something like B12 deficiency, neurosyphilis, even anemia. So these are the things that we should not miss. And coming back to the terminology again, I think sometimes when we said hand and then we just end it there, which I think is kind of like a missed opportunity. Broadly categorized asymptomatic and symptomatic, but again, I'm very cautious on asymptomatic. So the way we separate these 3 stages is basically using 2 sets of assessment, the cognitive tests and the activities of daily living assessment. And as you can see here, for SCD, the test will come back normal. So basically only symptom, but objective test come back normal. MCI, abnormal cognitive test, but doesn't really interfere with ADLs. And of course, last but not least, for dementia, affecting both. The million-dollar question is, which test is the best one? And straight away, I have no answer to that. But there are some of the recommendation in choosing, which I will get into, and some of the examples that I provided here are the things that we often see a lot. The first thing is International HIV Dementia Scale, 3 tests. SenSpec, moderate, quite all right, 65% to detect mild symptoms. A test 3 things, memorizing the word and then recall it back at the end of the examination. Motor speed using non-dominant hand, tap your finger as widely as quickly as possible, and the hand motor sequence, fist palm perpendicular, fist palm perpendicular. I think I would argue that a more common one, well, at least in Thailand, is Montreal Cognitive Assessment, or MOCA. One of the good things about it is it accesses many cognitive domains. The performance is excellent in detecting MCI in general population. But the problem, the argument, the debate right now is about the performance in people with HIV. Another great thing about MOCA is it has been validated and translated in so many languages, so many countries. This is the example. On the left-hand side is the original English version. On the right-hand side is the Thai version. The last example is moving towards the electronic, the computerized screening tool. One of the tools is called NeuroScreen from Professor Romans, and it uses smartphone or tablet, assess 6 domains. The performance is quite good. Now, the argument for computerized equipment has always been because we are dealing with people who age 50, 60, 70. Are they comfortable using these devices? My own opinion would be, in the near future, I would definitely say that should not be a problem. But even now, I think we can, and perhaps we should also measure the experience on the tablet or smartphone of each participant, so then we can perhaps see whether the results might be valid or not. So this is the kind of recommendation, because as I mentioned, there's no standard here. There's no best two yet, no consensus one. This is a paper from Lucette and her team earlier this month, kind of like some recommendation of how to choose the right screening tool. I think realistically and with high feasibility of really doing it, I think the key here for me would be multidisciplinary team. Ask The person who are familiar with these kind of tests usually would be psychologists. So I think those people can give you a very great opinion of what to choose, because it really vary depend on the culture and on your setting as well. Okay, so I'm just gonna mention briefly a bit about accessing activity of daily living. There are many ways to do that in our setting, both in HIV-NAT and also in Chulalongkorn University. We used to think the Barthel Index to assess basic ADL and Lawton Brody to assess instrumental ADL. I think there are other things that can be used as well. So right now, after doing the cognitive tests, assessing the ADLs, now we can categorize, we can pinpoint now that what the patient is having, the stage. But we cannot end there. We cannot end there. We have to always ask the question, what is the etiology of SCD? What is the etiology of MCI? What is the etiology of dementia? Hopefully, we can find those reversible causes. And that leads me to what to do next after detection. Coming back to this one again, so I think right now we are, okay, I can point you right here. We are around here now and moves toward to the right. And again, the biomarker is not really there yet in a lot of diseases. Besides Alzheimer's disease, our institution, HIV-NAT, have some work in using Alzheimer's disease biomarker to see the cognitive trajectory of people with HIV, which will be presented in CROI this year. But the data is not a lot yet. So after we detect the stage, right, SCD, MCI, dementia, etc., the next thing is we have to always find the etiologies. And the important thing is because we want to exclude reversible cause. Some of the things that's, I would say, like get a package that we always did because it's a standard from the dementia field is these labs plus structural brain imaging, brain MRI, preferably. But if if the patient history suggests, for instance, sleep issues, send them to do polysomnography. I have many patients have cognitive impairment because of OSA, improve after using CPAP. Perhaps any toxic. But the CSF and PET scan, I think it really depends on how much you want to go deeper in terms of diagnosis. For like Alzheimer's disease, CSF is one of the ways to do it. But again, right now there are plasma biomarker that quite equivalent for general population now. Besides all the fancy investigations, also don't forget to check concurrent medication. I cannot tell you how many times people have cognitive impairment because they use too many sedative pills. Mental health, one of the, I believe an older term now, pseudo dementia, we don't usually use that anymore. It basically means that people have depression, anxiety, and that leads to cognitive impairment, sleep issue, as I mentioned. Now talk about add-on the things specifically about HIV. Is there viral suppressed? ART toxicity perhaps? Any mental health, maybe like stigma related and all that stuff. Now, I think everyone, every patient with cognitive impairment must always be explore the underlying etiologies of it. But it is extremely more important for those who are younger. Those who are young, the proportion of reversible causes is definitely higher than older population, because older population usually the cause is neurodegenerative disease. But I still think it's very important to be able to provide that diagnosis for the confidence of ourselves as well and for the patient as well. Management, of course, specific to the underlying reversible cause. Hopefully there is some for that patient. But the thing that anyone can start doing in the clinic is risk reduction counseling. This is a landmark paper published in Lancet last year, stating that approximately 50% of dementia cases worldwide could be prevented by eliminating these 14, I'm going to put a quote, modifiable risk factors which lay across our lifespan. Well, I'm not sure like less education it is modifiable that much, but I think, yeah, in the sense that it's not genetics, it's not aging, yes. So these are the things that we can keep in our mind and raise awareness and provide patient education that could definitely reduce the risk of developing cognitive impairment, or, you know, if they have cognitive impairment, try to stabilize as much as we can. And last but not least, as you can see from perhaps the investigation, the stream library referral services, I think is still vital. Whether or not we can task shift to do as much as we can, that's great. But eventually, we would usually need like structural brain MRI, sometimes like polysomnography. I don't think that's going to be that feasible to do in the clinic setting. This is again coming back to the paper from who said earlier this month. Both sides of things, promoting and try to reducing these things. I think it's kind of similar to the one for the Lancet I presented last slide, but this is more adding on some of the HIV specific things as well. So that's the end of all I want to talk about. So key takeaway here. This is based on my own experience as well from the colleagues and also from seeing patients in cognitive clinic. I think approaching brain health in people with HIV similarly to other NCD, the example that I use like hypertension, diabetes, I think is a nice way to go. The burden, number of people with HIV with cognitive impairment is expected to increase. Why is that? Because age is the most unfortunately important risk factor. There is no consensus recommendation for screening. I'm trying to look at it optimistically, so that opens the door. You know, you can try, you can tailor what fits best to your setting. Be cautious about asymptomatic. Two-step diagnostic approach, staging, whether it's the staging of hand or whether you're going to go with SCD, MCI, dementia, that's only first part of it. The second thing, always find the etiology. As the neurologist will say, what is the lesion? Always evaluate potential reversible causes. We don't want to miss that. A streamlined referral system remains essential, particularly in some of the investigation, as I give an example for you. And to end in a positive note, we already have the tools to provide to our clients, and that's the patient's education, risk reduction counseling, which applies to everyone. So last slide is the acknowledgement to all the people involved that make our work in July in HIV-NAT, cognitive impairment, brain health, linking to people with HIV possible. And thank you very much for your attention.